All right. So, Dr. Chauhan, are you going to manage this little group here this afternoon?
Yes. I don't think it's busy. So happy to moderate this session. We have some fantastic panelists here. Uh, up and coming rising star from Vanderbilt, Dr. Das. We call him Nanu. He's great friend and a great advocate for our neuroendocrine tumor patients, and really developing and taking off where Dr. Berlin left, a very strong and robust program. And
Wonderful.
also here that Dr. Ramirez is joining forces with Dr. Das. So really strong program at Vandy. I have my colleague Rachel, who is a very integral part of our multidisciplinary neuroendocrine tumor program at Markey Cancer Center. She does such a terrific job with counseling our patients and managing and giving them tips. In fact, any patients with NET and function syndrome, she has to meet them unless she's not there. So that's how important she is, or the importance of having a good nutritionist on a treatment plan. We don't have a whole lot of questions, but there are a few questions trickling in, and we're going to try to tag team it. The first question is very specific, so I would advise patients to and caregivers to submit more questions, but try to not make it very patient specific, because medical legally we are not allowed to give a patient specific medical advice over the internet. And as you all know, there goes a whole lot more detail and nuance in giving the actual medical advice. So it can be inaccurate. So I'll try to summarize this question from the particular patient regarding a lung net, or seems to be thought to be a typical lung net, now metastatic. So the question is, why was this particular patient's NET spot negative despite it being a low-grade neuroendocrine tumor? And this particular patient seems to be having a rising titer of NET test. What does that mean, and what does that how does that affect the management? So let me make a brief comment, and then I will put that question to Dr. Das. As far as neuroendocrine cancers are concerned, the prevalent sites for NET cancers are your midgut, your small bowel, pancreas, and the third commonest site is lung. So lung neuroendocrine tumors are not as uncommon as we think. They are the third most prevalent site in the body. However, how they differ from the other GAP nets is that sometimes they don't have somatostatin receptors. So it is not uncommon for the NET spot or the octreoscan to be negative in lung or typical lung carcinoid. And this is even more true for atypical carcinoid. So as the grade of cancer increases, as the tumor becomes more aggressive and dedifferentiated, it tends to lose somatostatin receptors. So atypical carcinoids are even less DOTA avid, less somatostatin receptor in my experience. And higher grade neuroendocrine cancer of lung origin, like small cell or high grade large cell neuroendocrine carcinoma, have even lesser somatostatin receptors. In fact, in small cell lung cancer, it's reported only 20% maybe express somatostatin receptors. So as the grade of tumor increases, as they become from typical to atypical to high grade neuroendocrine carcinoma, they tend to have less and less somatostatin receptor, so their gallium scan can be negative. Having said that, sometimes, in my experience, thoracic neuroendocrine tumors, especially typical carcinoid, can be MIBG positive. That's another biomarker that is often seen in pheochromocytoma, and in my experience, sometimes lung NET, especially if they are somatostatin receptor negative, can express MIBG. Something to consider. But let me put the question to Dr. Das. Is that your experience with the thoracic NETs and gallium scans? And secondly, we currently don't have a lot of experience with NET test at Markey Cancer Center. Can you share your experience with NET test, and how does the rising titer of NET test? What would you do with that information?
Yeah, thanks, Dr. Chauhan. It's a great question, actually. So I completely agree with your sentiment that, lung neuroendocrine tumors express somatostatin much more heterogeneously. So even the typical lung nets actually only have about 50 to 60% of those tumors express somatostatin consistently. And that's in contrast to, some of the aspects that we talked about earlier in this morning, where well-differentiated gastrointestinal neuroendocrine tumors typically express somatostatin in about 90% of cases. So based on the presence of that receptor, the gallium scan is either going to be positive or negative. So particularly for lung neuroendocrine tumors, we find that an FDG PET can sometimes be more useful than a dotatate PET. Now, to your second question with regards to sort of the rising titers of the NET test, so this is still an area of active investigation. So we just got the NET test added to formulary at Vanderbilt, but again, it applies to very select patients. So patients that are undergoing surveillance for resected disease or those on a somatostatin analog, and we're assessing for disease progression. So my personal philosophy is that, this NET test, as we talked about earlier as well, is a measure of neuroendocrine tumor transcripts or certain genes that are responsible for neuroendocrine tumor growth. So as those levels rise, we certainly are concerned that there could be something lurking. But at this point, I think the strategy might be to do a little bit more aggressive imaging. So whether that's getting an FDG PET scan or perhaps looking at CAT scans at a little bit of a sooner interval, perhaps every 3 months or so, just to make sure that we're not missing the development of a neuroendocrine tumor.
Great answer. Thank you so much, Dr. Das. The next question is to Rachel. This is regarding a diet. However, the question is very specific, but Rachel, you can go ahead and kind of give us a general, non-specific answer if you wish. So patient had surgery in 2016. Now about 18 or 19 episode of small bowel obstructions. And it can happen very fast, and has sought multiple opinions regarding diet from various people. There is significant cramping and nausea, but no vomiting. For a patient of this sort, seems like the patient have either mesenteric disease or abdominal disease, and these small bowel obstruction is often common in this type of situations. Very difficult disease to treat from medicine standpoint as well, and sometimes difficult to operate on. Sometimes changing diet can help ease some of these cramping and these pain or small bowel obstructions happening from strictures, scar tissues, or tumors. So what would be your advice regarding diet in such kind of patients, and would you recommend antispasmodics? Does that help with these cramping type of pain? I guess the antispasmodic question I can turf to Dr. Das after Rachel.
Okay. So typically with any risk of a bowel obstruction, we look at first I would say, talk to your provider about how severe is the risk and how restrictive with the diet do we need to be, because typically we will do very low fiber to avoid a bowel obstruction. And as far as the cramping and bloating or nausea and things like that, look at foods that may be avoiding foods that are really high gas forming in digestion. Of course, that's cruciferous vegetables, broccoli, cauliflower, cabbage, beans, onions tend to cause a lot of gas. And a lot of the insoluble fiber foods sometimes can be gas forming. So I would say small amounts, things that are easily digested, plenty of fluid, and talk to your provider or surgeon about, how low fiber do you need to go to help prevent future obstruction.
Yes, clearly not an ideal situation. Sometimes it's very tricky, and even our systemic agents are not really good at kind of shrinking the tumors in that location. So it does help to have multidisciplinary approach, see if some of the tumors can be debulked, if surgeons feel so. Some of the treatments, active treatment, PRT and all that. In my talk, I did talk about risk of small bowel obstruction from the treatment itself early on. So it's definitely a difficult situation, but diet and changing diet can sometimes help improve certain symptoms. Dr. Das, any thoughts with that, and any supportive care medications, antispasmodics?
Yeah, I think so. I think one of the agents that Rachel mentioned earlier. It depends, right? So sometimes cramping can accompany symptoms like severe diarrhea, which can sometimes actually preclude bowel obstructions. In that case, truly, it's the diarrhea that's the driver. And in that instance, an agent that you and I have a lot of familiarity with, actually two studies ongoing at UK and at Vandy with Enterade. So some of the retrospective data that Rachel had mentioned, we're now testing it prospectively. But the advantage of an agent like Enterade is it doesn't truly have the constipative effects or the potential paradoxical worsening of some abdominal symptoms. I actually find an agent like Bentyl, a dicyclomine, quite helpful. It's sometimes gentler than Imodium, but can be more effective for cramping. But I agree that it's not an easy aspect because sometimes our treatments cause it and sometimes the disease causes it.
Right. All great pointers. And yeah, I am very excited about our studies, the phase 2 studies going at Vanderbilt and University of Kentucky with this novel amino acid based product that Rachel talked about. And we look forward to seeing these studies read out in the near future. All right. So there is a question about dosimetry. When will dosimetry come into play in PRT? So Dr. Das, take a stab at it. Can you explain to our viewers in very simple language what dosimetry means and what is the future for dosimetry in NETs?
Absolutely, and if it's okay with you, Dr. Chauhan, I think we can use this as an opportunity, as someone who's leading a number of PRT studies, as to perhaps providing some guidance for our listeners about what are some of the ones that you've described many, but which are the ones that you find most interesting, whether that's alpha emitters, whether that's newer forms of PRT. So perhaps we can bridge the two. But very simply, dosimetry is ensuring that the dose of lutetium that is given, or any radionuclide for that matter, actually reaches the tumor. So the nice thing about lutetium dotatate is that actually it gives off a tracer, which can actually be measured after the treatment through something called SPECT CT scans, just a type of scan that can actually assess whether the treatment is actually getting to the tumors. Now, in Europe, dosimetry there's been a greater uptake of dosimetry. In the United States, we actually don't truly know yet whether that makes a difference. But there are some trials in development, some of the panels that Dr. Chauhan had been a part of, to actually talk about guiding PRT dose based on dosimetry. So the big upshot or goal is that can we maximize tumor dose while minimizing other organ dose through these potential post-treatment scans.
Perfect. Thank you so much, Dr. Das. And yeah, I can chime in. I completely agree with Dr. Das. And this is under investigation. It's clearly not ready for prime time. But, there is another agent called Azedra, which kind of made it into prime time, and that uses dosimetry. So we are trying to dose. So the idea is that not everybody needs the same amount of radiation, and you should tailor it to the patient. So the idea sounds very good and catchy if we can able to tailor it. But this is clearly not ready for the prime time. And at least in one of our PRRT studies, we are going to be studying it, where we will do it as an exploratory endpoint and see how radiation sensitizer affects dosimetry. And we will be looking for the radiation dose delivered not only in the tumor but also end organ to see do we need to reduce the dose of Lutathera or not. So exciting concept, but still being discussed, and I look forward to seeing how it plays out. Now, Dr. Das asked a really interesting question regarding these new PRT studies, and there seems to be a lot of hype about it. Clearly, because PRT is one of the most active agents we have currently, which is on label, FDA approved. So, of course, there's a lot more excitement going on to what's next step and what are the next generation of PRT studies. And actually, there are quite a few on the horizon. Of course, I'll be biased about my studies, right? My studies will be better than others. I'm kidding. So, there are all sort of nice studies going on. The idea is how we can improve on the current Lutathera. And that one way to approach that is by adding another agent which would radiosensitize them. So using radiosensitizers, you are very familiar with a lot of DNA repair pathway agents. Dr. Das is himself doing very interesting and cutting edge trials in various other cancers, high grade cancers. But the same principle we are using with the help of triapine and now upcoming study peposertib in NETs, where we are adding to Lutathera. My colleagues from other institutions at NIH are using PARP inhibitors, and now very recently cabozantinib with a similar sort of rationale that VEGF inhibition also improves the effectiveness of PRRT. So that's happening. The other way to approach this problem is by trying a completely different type of radiopharmaceutical. So you brought in alpha particle, and that's a good segue into a question. So somebody in the audience asks, what's the status of alpha particle PRRT and prospects of it? So lutetium-177 dotatate is a beta emitter. And the advantage of or disadvantage of beta emission is that it has a longer depth of penetration, so the radiation travels far. So the issue with that is that there is a chance that it would also radiate somewhat nearby normal cells. Alpha particles or emission type of radiation is higher energy but lesser penetration. So the amount of radiation leakage to the nearby normal tissue is less as compared to, let's suppose, lutetium-177. So theoretically, that is what is exciting about alpha PRRT. However, we don't have a whole lot of clinical data. At present, there is a phase 1 study going in Houston with RadioMedics, and Dr. Del Pasan is the PI on that study, and they have disclosed some early phase. I think 9 or 10 patient data. It seems very safe, and there is some degree of effectiveness. But of course, it is just in phase 1. It will have to be tested phase 2 and phase 3 settings. So there is going to be some time before it's even ready for prime time, and that too if it is positive. There is also some very interesting preclinical work with alpha emission going on in Utah with Dr. Suarez group, where they're trying to test it, I think, in their preclinical setting, and they've gotten some grants from Net Research Foundation. So there is a lot of interest because, as I mentioned, it has potential because it is a higher energy and less penetration. But does that mean it's a better outcome is yet to be tested. So I think it's a very promising way to target neuroendocrine tumors, but we are going to be keenly observing how it goes. I think University of Iowa is also probably either studying or about to study this. Out of all these things, which one's my favorite? I think any research done anywhere globally, and not just US, I think is a step forward. So I'm always rooting for Dr. Das's study or Dr. Suarez's study or anybody studying anything anywhere. We want multiple effective agents. We don't want just one to be better than other. We want everything to be better. So I would not say that only my studies or Markey studies are better than others. I think they all are building on very good science and have good rationale, and they are really targeting the neuroendocrine tumors from different angles. So that really improves our chances of success, because if one strategy fails, the other might be able to cover. So at this point of time, it's very early to say which strategy to pan out: alpha emission, combination with the DNA damaging agent, or combination with immunotherapy. It's early on to say.
Yeah, Dr. Chauhan, if I could add, is one of the things that came up this morning is sort of the role, right? As you mentioned, this ongoing phase 1 study with the alpha emitter, it's in PRRT naive patients. There's been work from around the world, including in India, which alpha emitters have been used after lutetium. And so I think it's a very interesting paradox about what line to use it in. Perhaps should we sequence them? So lots of exciting questions to answer.
Right. No, I agree. I think anytime you're doing a study, which is first in humans or very early in the drug development, the normal consideration should be to use these untested therapies in a more high risk patients, especially when you have more, proven and tested therapies available for them. So again, yes, we don't know the true sequencing, and hopefully some of this prospective data would help us. All right, moving on to next question. All right, what do we have here? All right, Dr. Das, do you recommend that the same radiologist reads MRs and CTs? How is it done in your setting? And to follow patients, net patients, what do you recommend, CTs or MRs? What's your practice?
Yeah, so it's a fantastic question. So the answer, like many things in NETs, is it depends, and it's individualized. So we do actually have a dedicated group of neuroendocrine radiologists at Vanderbilt. So so we have an every other week neuroendocrine tumor board. So any questions on our scans, we bring it to them. So we actually have the consistency of having those same individuals review the scans, even though they may or may not be read by different radiologists. Now, it really depends on where the burden of disease is. So for many patients with liver predominant disease or a burden of disease in the liver, oftentimes the MRI actually gives you more sensitivity in order to look at the liver tumors and actually truly assess how they're evolving. For bone disease, CT can be quite good. So the truth of the matter is, usually if I can get by with CT scans for my patients that can visualize all the disease I need to see, I do so. And occasionally I will mix in MRI scans as well, but I don't routinely use dotatate for surveillance purposes.
Perfect. Looks like we have a very similar practice. That's great. All right, Rachel, next question is for you. Can you tell us or share us some resources regarding good nutritional advice online, either websites or certain books that you go to or refer to? I know as a medical oncologist, we can't remember everything. So sometimes somebody would ask me, hey, doc, can I use this drug? I remember this drug from med school, and there was some interaction with heart medicine. Let me use up to date or something of that sort. So are there any easy open source which anybody can access to resources regarding nutrition, especially for NET patients?
Yeah, the Carcinoid Foundation has a lot of good information online. A lot of even presentations from other dietitians are available as far as nutrition is concerned. I do also, as far as just generally healthy eating and nutrition related to cancer and cancer prevention, I send folks to the American Institute of Cancer Research quite often because I feel that they're pretty well rounded in their advice and what they recommend. But always happy to point patients in that direction.
Gotcha. Perfect. And Rachel, as a follow-up question to that, what would be your advice to patients with fatty liver? This seems like a big growing problem. To be honest, I think every other patient has have some degree of fatty liver. And even non-NET patients, I think it's a big problem in our general population as well because of our lifestyles and the diets we've changed. So how do you counsel patients regarding dietary changes in fatty liver management?
That's a good question because I do have several patients that are experiencing fatty liver at the same time, and we're trying to manage both that and symptoms of carcinoid. So typical nutrition recommendations for fatty liver are lower fat diet, so lower animal fat products, more plant-based foods. You don't have to go completely plant-based, but leaner proteins. Also eliminating a lot of the processed foods. A lot of additives, a lot of corn syrup, a lot of concentrated sugar sources that are just tough for your liver, especially if it's not functioning as properly to begin with. It's hard for the liver to filter that. And exercise, limiting alcohol, avoiding alcohol, even and losing some excess body weight can help. So the generally healthy diet is typically low fat. That's appropriate for fatty liver. But I would look at a lot of times food labels and what kind of extra additives or hidden sources of added sugars are there. Our Western diet is pretty full of that stuff. So any of that packaged and convenient food is going to be something that you may want to moderate and limit. Anytime you can fix something fresh at home and start with more fresh and pure ingredients is going to be easier for you to process, your body and your liver.
I agree with you, Rachel. I think that's a great advice. And not just, I can attest to it, not just Western diet. I think it's a problem everywhere. Even in Eastern diets, like Indian diet, we can pack in a lot of starches and carbs and, flour and rice and all those things. I think the refined sugars are even worse. And the concept, it's now very well understood. This sugars convert into fat, it gets stored in the liver. Especially in our patient population where liver mets the number one site for metastatic disease. We really want to preserve health of liver. And because, that's abnormal liver functions, the number one cause of why we lose NET patients from progressive disease. So if we can do whatever we can do to help, optimize liver function and keep liver healthy, that's definitely a welcome step. All right, Dr. Das, it looks like we have a question for you. What type of physicians are in your NET team? So I guess we can open this a little bit more broadly. What does a NET multidisciplinary clinic look like? We usually have the stocks, otherwise NET multidisciplinary management. So our new folks here probably don't know that NET's usually managed by not one doctor. We might be the face, but there are a village behind us. So what does the NET multidisciplinary team look like? And this particular patient lives in Tennessee, so would like to see you. So is it possible to get all treatments and testing and all that done in 1 to 2 days? And how to get in touch with you? Can you share some detail about your patient coordinator, stuff like that? What would you tell them, how to get hold of you?
Yeah, absolutely. So starting with the first point. So I think, one of the big sentiments that that all of us always echo is that when you get diagnosed, if you can, to go see a NET specialist. And what we're really saying behind that statement is to see a NET team. And many of the centers, UK, Vanderbilt, several other places around the country are blessed to have a multitude of specialists who focus on different aspects of NET care. So, for example, the easiest way to think about the NET specialists that make up our team are those that are often found on our tumor boards. So you'll have our medical oncologists, such as myself. We have our surgical oncology colleagues who work right next door to us, so see patients actually oftentimes on the same day as us. We have our interventional radiologists, the folks that deal with liver-directed therapy. We have our nuclear medicine physicians who we work closely with to deliver PRRT. We talk about dosing for each individual patient together. We have our radiologists, our traditional imaging radiologists as well, and our radiation safety colleagues who actually make sure that the rooms are safe for sort of Lutathera to be administered in a way. So that's comprising our team. Absolutely. So if you were to come see me or Dr. Ramirez, we could get everything done in a day or two. Usually, as long as there has been some scans done outside, or we can even coordinate the scans ourselves. Usually, if you just Google my name at Vic VICC, there's a referral line, and if you ask your doctor to go through that referral line, we would be more than happy to see you and could do so in a quick manner. So,
fantastic. Thank you so much, Dr. Das, for helping our patient not just in Nashville but around surrounding areas. All right, Rachel, question for you. What type of mineral vitamin testing would you recommend in patients who have had pancreatectomy or Whipple surgery, don't have pancreas?
We're probably usually looking at the nutrients that are absorbed in the parts of the GI tract that have been removed. And B12 is probably one of them that I would look at. But I would also, if we're showing signs of something else that could be nutrition related, a lot of times we don't have to supplement. But if we can kind of mitigate the fat absorption, then you're absorbing those fat soluble vitamins, and that can be done with of course, the pancreatic enzyme replacement. I have had Enterade work with some of those patients that have those have some of those symptoms. So I may not say, oh, let's test your copper or your zinc. I kind of would look at what's your weight. How are you eating? Are you having enough protein? Are you showing physical signs of malnutrition? And if we need to look at, of course, electrolytes, which those are usually in a normal panel of labs that they draw. So it kind of just depends, but a lot of times we're looking at that whole picture. If that helps.
I agree, Rachel. I think a lot of it is also art and science of medicine. We should not always do all the testing on everybody. And we should look into certain symptoms and nutritional deficiency symptoms, and on top of that, risk factors that in this case, let's suppose surgery, and put it all together, because all these extra tests and everything does add to financial toxicity, both to the patient as well as healthcare system. So you're very much right. There are certain tests that we should do, others should be considered based on individual needs. All right, Dr. Das, there's a question regarding Afinitor, everolimus, and insulinoma. How is your experience with that? Do many of your insulinoma patients who are on Afinitor actually get a desired boost in their blood sugar? That's the quote unquote question. So you want to throw some light on functional NETs in general and Afinitor?
Yeah, absolutely. So functional neuroendocrine tumors vary by site of origin. So actually, the small bowel is the site of our most common functional neuroendocrine tumors, but naturally, the pancreas can also cause functional symptoms. So amongst the pancreatic neuroendocrine tumors that are functional, which is actually only about 5 to 10%, insulinomas actually tend to be the rarest of them. However, insulinomas can actually be very much a challenge to treat because sometimes, paradoxically, our somatostatin analogs, octreotide or lanreotide, can actually bottom out blood sugar for those patients. So in my experience, I've found that whatever systemic therapy it might be, I've actually used Captem or capecitabine and temozolomide successfully in these patients, and actually even Afinitor as well. But you're right, the individual asking the question is that one of Afinitor's side effects is raising blood sugar some. But I actually I think that's an outstanding point. I don't think it's specifically been studied in that niche, but I think achieving disease control for an insulinoma through systemic therapy, whether that's through PRRT, capecitabine and temozolomide, or Afinitor, can actually improve glucose control.
Sorry, I was on mute. Thank you so much, Dr. Das. I completely agree with you. I think it is a rare situation, so it's not that we have tons and tons of data or we see this often. But insulinoma, when we do see them, could be problematic. Especially, I've had patients which needed a continuous glucose line, and so it could be that bad in certain situations. However, the bottom line is to cytoreduce the tumor. The lesser the amount of tumor, the lesser the amount of insulin which would be spilled on and cause these symptoms. So I completely agree with you. I love Captem in this space, and I think it works really well. PRRT also works. So whatever can shrink the tumor. Afinitor by itself, how much it'll bump the sugar? Probably not so much. I think it's through the effect on the tumor per se that it might see the indirect benefit. But certainly one of the drugs can be tested in this space. However, it's an interesting nuance. Afinitor was FDA approved for non-functional neuroendocrine tumors, but we use it, because we don't have a lot of options, right? Okay, next up. Should the children of NET patients be tested? How do you, in your practice, Dr. Das, how do you pick and choose who should be considered for germline testing? And also throw a little light on germline mutations and somatic mutation. What does this mean? And, risk factors for the inheritance of certain of these things.
Yeah, that's a fantastic question. So what germline mutations confer, or what they mean, is actually mutations in our own genes that are passed on to every cell. So a somatic mutation is actually one that occurs in the tumor itself. So, for example, if a tumor has a certain mutation, that does not necessarily mean that our own cells possess that mutation. However, if a tumor is caused by a germline mutation, and we'll talk about a few, that means that that mutation is present in all cells, and it can actually cause other issues as well. So, in general, we don't think of neuroendocrine tumors as a hereditary disease per se. If we look at the numbers, usually about 90% are sporadic, meaning they happen by chance. But the way I tease out who needs germline testing or which patients do, particularly with regards to children or other family members, is one is actually age of onset. So be curious to hear Dr. Chauhan's perspective, but we're seeing younger and younger patients in our clinics. So if a particularly young patient, let's say under 40, has a diagnosis of a neuroendocrine tumor, even in the absence of an obvious family history, I will be compelled to get them germline testing. There are subgroups of patients, though, that have certain syndromes that actually are associated with familial syndromes. And those include things like VHL, von Hippel-Lindau. Those include, so for example, if patients have kidney cancer or thyroid cancer in their family, even if they don't necessarily have a neuroendocrine tumor, that raises my flag to think about germline testing.
Yes, thank you so much. And I agree with you. I think although we have to be a little careful because we are a tertiary care net specialized center, so we do have a lot of referral base, a large catchment population. So some of these things that I agree with you, we are seeing a lot more younger patients. In fact, we at Marquee just launched a pediatric neuroendocrine tumor program. So we are seeing MEN patients, young patients for MEN screening and neuroendocrine tumors, teenagers, and even high-grade neuroendocrine carcinomas, early 20s, small cells. So we are seeing some of those. Is it environmental? Is it something that they're being exposed to? Or is it just the fact that we are a referral center and we are just seeing a lot more volume because they're coming to us for second opinion? That's yet to be deciphered. But thank you so much for because it is very distressing for a lot of parents to see, do the kids need to be tested? So the answer is I agree with you that it is not the common, it's not the norm. It is rare to have hereditary risk factors. And just like Dr. Das suggested, if the onset is in young age, yes, maybe then it makes sense to screen their kids. But most of the patients who are diagnosed in 50s and 60s, and it is just a chance thing that happened that caused their mutation rather than something that inherited. If the patient have other risk factors of other endocrine gland tumors like thyroid cancers or adrenal issues or pancreas issues, then yes, talk to your doctor. Then they would do a thorough family history, personal history, and then decide whether you would benefit from screening for germline testing. Adding germline testing unnecessarily can be very stressful for everybody and families. So let me reiterate again, if you don't have those risk factors, the chance of your family having one of those hereditary conditions is very, very low, not to be worried about. Okay, Rachel, very interesting question for you. I'd be curious to see what you answer. Have you heard cooked tomato like tomato sauce okay in carcinoid, whereas raw tomato more problematic? Or you should avoid both, number one. And secondly, are there some non-aged cheeses which you can eat? Very interesting. I'm completely stumped.
Yeah, I think that as far as the tomatoes concerned, the cooking process breaks down the fiber, number one. It also makes lycopene, which is a beneficial compound, more available. So it's possibly the cooking process. I'd have to look into that a little more. I feel like someone has mentioned that to me before. And a lot of times with cooked tomato products, you don't have the seed component or the skin at all. So that may be another thing. I don't know that it breaks down or the serotonin levels in the food. That's a very interesting thought. I'd definitely be interested to read more about that. The cheeses, so mozzarella cheese is usually pretty fresh. You can get some probably not as aged cheddars, but a lot of those, I mean, if you think blue cheese, Parmesan cheese, some of those really fancy charcuterie board cheeses are going to be too aged. But I think probably it depends on, on what you tolerate. And some people are able to tolerate a little bit of it, and some people not as much, if that is helpful.
Thank you so much, Rachel. And a lot of it is quality of life. You have to put everything in perspective. I recently saw a patient who initially presented with a lot of flushing and carcinoid syndrome symptoms. We were able to, control it with embolizations and Afinitor and Zermello and somatostatin analog to a point that the patient is completely asymptomatic. Okay. Now the patient's asking, hey, doc, can once in a while I have a beer or a glass of wine, right? So if it is not bothering and in limitations, right, and moderation, if it adds to their quality of life, if this is something that they look forward to hanging out with their friends and they want to just grab a glass of wine and it's not causing them to have issues while we have kind of controlled it with medical management, I think that has to be also put in consideration. So everything is in balance, okay? So if something works in a particular way theoretically, yes, it's good to avoid those things, but always take a break here and there. Would you agree with that, Rachel? Or
yeah, absolutely. If you can handle it and it's not bothering you, of course, moderation with things like alcohol. But that's the point that I kind of wanted to drive home, is that I want to liberalize the diet as much as possible. So just because this may generally cause a problem for folks, it may not for you. It may at some point, it may not at others, depending on what type of control of your disease is. So yeah, and if you can eat tomatoes, do it.
All right. And Dr. Das, in the same breath, what about physical activity? What do you recommend to your patients? Do you encourage them? Do you dissuade them from doing exertion, especially with functional syndromes? What is your take on that?
Yeah, it's a fantastic question, and I think it's very similar to how Rachel's describing food. I think it matters on, what are the day-to-day stressors that can seem to trigger your tumor, right? If it's something as unfortunately as simple as getting on the treadmill, which it is for some patients, then we are more limited. But I think for the most part, in patients that I see, light aerobic exercise is an outstanding way. Oftentimes getting in the pool and water exercises are more gentle, have a less of a sort of an epinephrine stimulating means, but I encourage my patients to get out and be active as much as possible, because I think it just beyond the body is the mind's impact as well too, right? And so we know, and that's perhaps a whole nother topic, but the impact of chronic stress and even just the day-to-day worries that can contribute to sometimes tumor-associated symptoms. So I encourage patients as they can act to do so. And for those that are perhaps more limited, maybe light aerobic activity is usually what I find to be a nice effective means.
Absolutely. I cannot emphasize the importance of de-stressing. There is some really good data that stress suppresses your immune system, affects wound healing. Unfortunately, we just don't have data in NET patients and how it affects, but I can tell you stress cannot be good, right? So easy said than done, but I always encourage patients to kind of find their ways to de-stress themselves. And that could be just engaging in social activities they like. But there are certain exercises which are known and proven to cause a calming effect. These can be from deep breathing exercises or light physical activity. And they are, the best part is they're free to do. You don't have to go to a gym or join a membership. You can log onto YouTube, and there are plenty of good lectures on how to do this at the comfort and safety of your home. But certainly, I think stress plays a major role, not just for NETs, but in your general well-being. And that's fantastic. All right, we would wrap it up now. Looks like a lot of questions. I wasn't really expecting this much questions, so we are almost done with an hour allotted time. We will finish with one last question, and that is related to nutrition. And I'm so glad that Rachel is here, because me and Dr. Das would have been completely in trouble otherwise. So, is almond milk and coconut milk same thing like the actual nuts, or should you be avoiding both?
Good question. So the almond milk and all the milk that is made from nuts, it doesn't have the fiber. It doesn't have the insoluble fiber, because it's kind of in the way that they make it. At least I know the way that people kind of have home make it, is that they soak the nut in water, and so it's really the fluid and the kind of leaching out of some of those nutrients and flavor, but it doesn't have the fiber part. And a lot of times some of the non-dairy milks are easier for folks to tolerate that are experiencing diarrhea. So if you do better with any almond milk or rice milk or any other, or the coconut milk, and typically in the grocery store, the coconut milk in the milk section doesn't have all the fat. It's much different than the canned coconut milk that has all of the saturated fat that gathers at the top. Typically, that's kind of filtered out. So look at the nutrition fact labels. A lot of times they don't have as much protein as dairy milk, but if it's easier on your system, which a lot of times for people it is, then I think that's totally fine.
Great. I think I missed one last question, and Dr. Das, we would like to finish off, because you've been here since morning. We really appreciate your time. So a patient has a 2 centimeter grade 1 well-differentiated neuroendocrine tumor, looks like close to junction of stomach and small bowel, and the recommendation from the primary doctor is to remove it along with the pyloric sphincter. Are there any other options besides surgery? What would you recommend in this situation?
Yeah, so I mean, it's a great question, and I think it's one that warrants a multidisciplinary discussion, because I think the first question is, what problem is the tumor causing, right? Because we know it's a low-grade tumor. It's one that is slowly changing over time. So one that we don't need to act immediately upon this tumor. The question is whether we think about surgery and what that actually means in terms of what the reconstruction looks like. I think having a detailed discussion with the surgeon to talk about what is the quality of life impact of such a sphincter potentially removing surgery and what that would mean on the day-to-day, versus potentially even getting a dotatate scan to look at the SSTR avidity, and potentially either observing or even treating with the somatostatin analog. So I think before I would think about jumping to surgery, I would really want to have a discussion with the surgeon to talk about what the quality of life implications were, and if they seem quite drastic, then perhaps doing a strategy with closer surveillance, potentially even incorporating a medical oncologist, could be a reasonable way to go.
Right. I think that's a wonderful answer. I completely agree with you. I think the general rule of thumb is, if it's an early stage NET, go for surgery. But every patient needs to be individualized. If the surgery would leave more morbidity, then you really need to know what's the end goal for that particular patient is, and need to discuss, like Dr. Das suggested, weigh in the risk and benefits of potential surgery, and the long-term side effects, reflux disease, nutritional deficiencies, and other things, right? So the surgeon would help us, discuss with the patient what type of recovery period we are looking post-op, and what type of long-term complication we are looking at this type of surgery. Potential benefits would be the tumor would be gone. However, there is a divided opinion about, can we cure these cancers, because there's always going to be long-term risk for relapse. However, the recommendation is, if we can take the tumor out in early stage, technically we get rid of the disease and there's less chance of it spreading. Having said that, Dr. Das, I mentioned, sometimes we have patients who don't want surgery for XYZ reasons, or are not good candidate for surgeries because of comorbidities or medical problems, heart problems, other things. Then observation is a very good approach. Some of these low-grade NETs might have been there for several years, sometimes several decades, without causing any problem. So if they are not causing problem, you can watch them and understand their biology. If they are growing and you have to treat them medically, I agree. I like the idea of trying somatostatin analogs. There are a few cases where I've seen drastic shrinkage in gastric NET with somatostatin analogs. It was very bizarre, but it does happen. So there are some non-medical approaches as well, needs to be factored in and tailored for particular patients, looking into all risk and benefits. All right, that was a fantastic Q&A session. Bob, I would like to invite you back. Many thanks to Dr. Das and Rachel for being here and answering these tough but very important and very interesting questions from our NET family. Thank you guys for sticking around. I see you guys, still plenty of people here on a Saturday afternoon, so great. And looking forward to see you guys again. Before I leave, I would want to remind everybody that we are having a national symposium in person in Atlanta, and all these familiar faces would be there. We're looking forward to seeing you guys in person. I've heard Marion throws crazy parties, so it'll be fun as well, and seeing people in real life. Of course, we will take all the COVID precautions, distancing, masking. Hopefully everybody will be vaccinated by then. All right, signing off.
Yes.
Seeing everybody.